Now, I would like to invite Dr. Deepak Agarwal. Deepak is working in Siliguri Greater Alliance Hospital. He is a prolific surgeon. So, he will be talking on scleral fixation of IOL.
Yeah. So I'm here to speak for myself. The previous talk was given on behalf of Dr. Amitav, and this is my personal talk. So I'm going to speak upon the scleral fixations of IOLs. This is the technique which I have learned from my mentor, Dr. Shubhendu Ural sir, and this is my experiences. These are all the surgeries have been performed by me. So I have no financial disclosures pertaining to this talk. So after a complete vitrectomy, we do small peritomies at 3 o'clock and 9 o'clock, followed by cautery. Now a curved paralimbal scleral flap is made approx 3 millimeter away from the limbus, and the flap is extended to approx 1 millimeter towards the limbus. And the sclerotomy is being performed with a 25 gauge trocar. Similar process is repeated on the other side. It's extremely important to make sure that the two sclerotomies are absolutely 180 degrees apart. In all my cases, I use a multi-piece foldable IOL. So these are the glued forceps IOLs by Dr. Amar Agarwal sir. The foldable IOL is being injected. With a weighting haptic, with a weighting forceps, I catch hold of the haptic. It's extremely important that you hold it at the edge of the haptic, and the haptic is externalized. Now I insert the forceps from the other side, and using a handshake technique, I use the other forceps to guide the haptic to the forceps which is using from the sclerotomy site, and thus both the haptics are externalized. Now we create a scleral tunnel. Mind you, initially it was a scleral flap. Now we are making a scleral tunnel with a 26 gauge needle which has been filled with dye. The dye is injected for better identification of the tunnel, and very nicely and very gradually the haptics are fed into these tunnels. The similar process is repeated on the other side. And in the end, it's a very nicely stable, centrally placed SFL. And in all my cases, after placing an SFL, I do go in again and give a thorough examination of the retina before closing the case. Thank you.
Do you use glue to kind of close the peritomies, or you cauterize?
No, sir, these are glueless surgeries.
These are glueless surgeries. Okay. And have you had a problem with the haptics once in a while? Number one. Number two, do you use the same kind of like IOLs, or you have different brands that you use?
Not to name any brands, but we are using the foldable multi-piece IOL of a very high quality brand, and in majority of the cases we are using that particular lenses only. In very rare cases where the patient is not affording, then we can also place a rigid IOL. I have placed rigid IOLs, but that is in once in a while. Say if I am performing 50 surgeries of foldable IOLs, maybe two of the patients have rigid IOL as well. But it's more easier to use a foldable IOL with a multi-piece foldable IOL.
Deepak, nice presentation. Regarding bands, actually, what happened in our hospital, two bands only available. So I am telling the name also because facing the difficulty. So one is Alcon, another is sensor. Right now, sensor is not available. Availability is very issue. But with Alcon, their haptics are very much flexible. So sometimes what I can getting, I am also doing similar to this procedure only. But sometimes the haptics little bit bend or the curvature with the optic a little bit change. So position of the optic little bit deviated from one side. Sometimes it's happening.
It used to happen in the initial part of my surgeries when there was a learning curve. As sir also asked that whether there was any problem with the haptics. Yes, initially when I was doing my first or second case, maybe up to the fifth case as well, at times the haptics used to come off. But after doing some amount of surgeries, they are not doing so any well, because once you are doing this, you come to know of how much traction to pull, with what force should you pull, and uh, to be based with your own hand, but gradually you learn. So to be very frank, now I'm not facing any trouble with the haptics. They comes out very easily, and yes, at times if you're not catching hold at the tip, it should be caught at the tip, and if you're not catching at the tip, then you might have some curvature of the, again there is a particular curvature and then it might turn again. So that happens if you're not catching at the tip. And even if you are catching a little further away from the tip and it bends, you can always cut it. You can always cut it if the haptics are very large, but you should not cut to a very large extent so that there is nothing left to put it into the tunnel. And majority of my cases remain stable. At least I have 18 months of follow-up, so none of the case has shown any major deviation or any major tilt of the IOL till now.
Actually, stability is not issue. Issue is astigmatism. IOL is little bit deviated from one side.
Astigmatism is often there in most of the cases. If you are getting an astigmatism, say up to 1 or 1.5, that's acceptable for SFLs. Yeah, if you are getting an astigmatism up to the 3, if the astigmatism reaches 3 or more, that is always a cause of concern. But if you look at most of the studies which has been published, and even in your cases, if you look into that, majority of patients do have an astigmatism of say -1, -1.5. Very fortunate patient might end up with astigmatism of 0.5 or something. But yes, some amount of astigmatism is always there.
Regarding the placement of the IOL, to quote our teacher, Dr. Pramod Bende sir, a 7-degree tilt of the IOL is acceptable in case of SF IOLs. So that is something that one has to keep in mind. Regarding the choice of IOLs, the more you do with any particular type of IOL, it becomes like your kind of cup of tea basically, because since you mentioned two names, one is not available at this point in time with us. Most diopters are not available, whereas the other one is available. So initially it was to save costs. The sensor IOL, multi-piece IOL, was available at a lesser cost to us, and we passed it on to the patients. But subsequently, all diopters of sensors is not available at this point in time, sensor multi-piece. So we are almost exclusively at Disha. We are doing with the Alcon multi-piece lenses. No interest financial for me or any of us in Disha on this. But gradually, we found that this works as well. And it's important to realize that, you have to have a sufficient amount of the, haptic to tuck in. Only in pediatric cases, you can cut off some of the the part of the haptic in case you feel it's a very long haptic. Otherwise, in most cases, with the Gabor's carry-out technique or whatever technique you are following, including your technique, so basically you can tuck in the IOL and this tuck in the haptics. And the important part is the tip of the haptics, haptices should not be exposed. So But of course, then there are controversies regarding this. With Yamani's technique, you just sort of leave it subconjunctivally, or not always. I have seen that it stays within the scleral tunnel. So this is probably, the jury is out on this. Yeah.
No, conjunctiva, just as we do for this SICS cases, we just cover the flap with the conjunctiva. Yeah, yeah. Yes. Uh, See, if you ask from a very much from a vitreoretinal point of view, we will always say that yes, base dissections we do in all the cases. Because whenever you are entering from the sclerotomy site very close to the vitreous base, there can always be a pool, or even while you are taking out the vitreous from the vitreous cavity, you are taking out the haptics externalizing, there might be an additional pool which can cause tear, unfortunate tear, and it can lead to RD. And these patients, they want very good vision, because initially they were going for a cataract surgery only. This is a, I feel it's necessary, but points may differ. We are doing it.
I think you have the best of both worlds. You moved on from being a prolific phaco surgeon to a VR surgeon, a prolific one at that. So like now it's your take. But for a lot of the cataract people who cannot do a complete surgery, then basically one has to ensure that there is no vitreous that's going to come into the haptic, or the where you are taking out the haptic from. So basically, it's a good idea for them not to, go in through the anterior segment corneal, section for the vitrectomy, rather going through the pars plana, because most phaco machines have, vitrectomy equipment now, and you can make two trocar cannulas and do a excision of the vitreous as far as possible up to the region where the anterior segmental surgeon is trying to take the haptic out from. So I think that part is very important. But having said that, for us VR surgeons, complete vitrectomy is what we've been taught, and that is what should be done ideally.
One thing which can be done, like if you are elected to do the entire full base dissection, what can be done is that where you are making the sclerotomy ports, those areas should be done, like their base dissection has to be done in that part mandatorily, because once in a while you can end up with a RD after SFL.
Yeah, that's what for VR surgeons it's easy, but for an anterior segment surgeon without the endo illuminator, and it becomes difficult. So thank you, Dr. Deepak. I think we are impinging on the time of the next. Yeah, sure. Initially, for this publication, before this publication, we were doing it after the fluid air exchange, but now we have realized that doing it before the fluid air exchange opposes the retina much better, and then you can finally, do a fluid air exchange and drain the fluid. So that part is to be done obviously after the fluid air exchange, but you can massage it before you do the fluid air exchange. So it works better. And for this, one of our presenters showed the high mag lenses. I think you showed the high mag lenses. So these are available from various agencies or instrument manufacturing companies. So even if you are doing non-contact vitrectomies, like you are using a biome or something of that sort, so it's a good idea to use a high mag system which is self-stabilizing, and do that part of the procedure using that high mag system. So that will ensure good success, very good success.